All right, so I want to bring up our next speaker, Dr. Darryl Kaelin. He is the medical director of the Fraser Rehabilitation Institute in Louisville, Kentucky, and he's really a physician who's spent his entire career redefining what it means to recover from a stroke, a brain injury, and many other neurological challenges. I know Dr. Kaelin personally. I have recommended many people to him because he takes a very different approach and one that we recommend you find in your search for a good caregiver, and that is partnership. He doesn't just see a diagnosis when you go to him, he sees a person behind it, and he works to individually find your specific strengths and build the connections with those strengths to help you recover. So integrating those therapies, etc., that you can use to grow on your own. His commitment to his patients is really what drives his second hallmark, which is an exhaustive pursuit of the latest research. Dr. Kaelin is really all about learning as much as he possibly can and integrating that into his practice. He doesn't want to stay static, and he's constantly scanning the horizon for the next breakthrough, which is why he's here today to speak to us, because he's become one of the leading physicians for the rollout of Vivastim, which is an FDA-approved therapy that uses paired vagus nerve stimulation to help rewire the brain's motor pathways. And our last conversation was about the bottom half of the body, and Dr. Kaelin is really going to be talking about Vivastim's use for the upper limbs and mobility for that. So, Dr. Kaelin, welcome to our conversation today. Thank you so much for joining us and sharing your expertise.
Thank you, Sherry. I appreciate the very kind introduction, and I welcome everybody who's on today and look forward to talking with you over the next hour about some really exciting new treatments that are now available for people with chronic stroke. As Sherry said, I'm a rehabilitation specialist. I've focused my career on neurological rehabilitation, and I'm a big believer in neuroplasticity and that recovery really never ends. It just depends on what new techniques and methods you're going to use to try to continue to expand the body and the brain's ability to respond to things and improve. So looking forward to talking with everybody today. As I mentioned before, I've been a rehabilitation specialist interested in neuro recovery, particularly focuses on the brain and the nervous system for the last 31 years. And this new technology for recovery after stroke is very exciting, but it's technically not a new technology. Vagal nerve stimulation has been around for decades, treating people with conditions such as seizure disorder. It's a very safe treatment method and a safe surgical procedure. So it's something now that we're just expanding its use into a different area. So we'll talk a little bit about that. Next slide here. Let's see if there we go. Good. So as many of you all know, stroke in America is one of the leading causes of disability. There are about 800,000 new strokes every year. That number has gone down over the last decade or two, primarily to the reduction in smoking and the improvement in acute stroke management with thrombectomy and clot busters that we use now to reduce some of the deficits. But yet there are still 7 million survivors in the United States every year. And so as a result of that, we have a lot of people with limited function in their arms, their legs, difficulty with talking, et cetera, that are looking for answers of how they can continue to improve their function. So Vivastim is the first FDA-approved treatment for people with chronic ischemic stroke. It is a stimulation device that is implanted, and it is intended for people who've had strokes with loss of oxygen in their brain from a thrombus, a clot, or something of that nature. Currently not available for hemorrhagic strokes or strokes that happen from bleeding, from a rupture of a vessel or an aneurysm. But I do think that it will work effectively for those. So there's research going on to try to gain that additional FDA approval in the future. So for those who might be listening that don't have ischemic strokes, but maybe have other kinds of strokes or even a brain injury of another kind, I think hope is down the line that this will get approval for a wider spectrum of individuals. It's particularly focused on improving people who have hand dysfunction. So people who have moderate to severe arm and hand impairment, and we'll kind of qualify what that is in a couple of minutes. And as you can see here, if you can see my arrow, this is a device that's implanted under the skin, typically in the chest, most often in the left side of the chest, and is a wire is moved underneath the skin, and then a small incision is also made in the neck, where the wires are then wrapped around and attached to the vagus nerve. So anybody who doesn't have who has had a surgery and doesn't have a left vagus nerve, or who has any injuries to those areas, wouldn't be eligible, but that's pretty rare. So most individuals are eligible for the implantation of this device. Advance slide here. So this is the paired components that go into this. It's a small stimulating device, and this device is implanted under the skin, much like a pacemaker. The wire is attached to it, which then creates the stimulation, and then the electrodes are wrapped around the vagus nerve in the left side of the neck. In the early phases of recovery, a person would go to a therapy clinic where the transmitter would be turned on, and then the vagus nerve would be stimulated during the period of time that a person gets therapy. Later, an individual can have a magnet that will temporarily turn the stimulator on, and that they can use this while they're at home doing exercises themselves. Mm. So we call this paired vagal nerve stimulation because, as with most things, you can't just do the stimulation alone and get the improvement. This is paired with aggressive intensive therapy. And so this microtransponder, as we call it, the Vivastim device, is intended to use to stimulate the vagus nerve with rehabilitation therapy. And this is designed to have lots of repetition of upper extremity function. Typically, we ask an individual to focus on one or two things they really want to improve on, and then we do a lot of task-specific repetitive activity, between 300 and 500 repetitions in a session over a couple of hours, in order to try to drive the neuroplasticity to occur. An individual will talk about who are good candidates, but typically we're thinking about somebody who has a little bit of shoulder movement, a little bit of elbow movement, and a little bit of finger movement. And if they have those, then they would be an ideal candidate for this kind of a treatment. They'd also need to be at least 6 months out from the time of their stroke, so we consider them in the chronic stages of recovery. And as you can see, this is what typically happens with rehabilitation in America. As an example, if you've had a stroke and you get a sudden decline in your overall function, and then over a period of days and weeks, you get improvement, especially if you go through aggressive rehabilitation, either in the hospital, in a rehab facility, or in a skilled nursing unit, or even home with outpatient therapy. There's periods of up to about 6 months where we see people making nice, steady gains in arm or leg function. But when we get past that 6-month period, two things happen. One is we start to see the recovery slow down, and we start to see in American healthcare, you've exhausted your therapy benefits. You've gone to your inpatient rehab, you've gone to home therapy, you use your outpatient, and now you might go through a period of several months before your insurance starts to kick in again. And so it's left up to you to kind of continue the exercise and continue improvements. So with that, we often see some people who remain very active and aggressive in their care see slight improvements that go on. We see a lot of people who stay about the same. And then sometimes, because people just kind of give up or aren't able to do as much without assistance from others, we see some people decline. And so the goal of this treatment is to have people continue to make progress for weeks and months beyond that static chronic stage. And so how does this work? Well, again, we really like to focus the brain's ability to respond to the electrical stimulation. If you think about our body, it's a body of electrical networks. Our brain sends a message down through the spinal cord, out through the nerves, and to the neuromuscular junctions, and ultimately to the muscles to make us work. Similarly, we think through connections in the brain. We talk through connections in the brain. And so what we want to do is improve the connections of the brain and the brain's ability to respond to external stimulus. And by using this electrical stimulus of the vagus nerve, it heightens the brain's ability to respond to the therapy that we give them. So we turn the stimulator on. They do a lot of high repetition work. Where the current treatment is 3 sessions a week for 6 weeks, so 18 sessions of therapy following the implantation of the device. And what we know is that many of the neurochemicals in the brain, including acetylcholine, which is very involved in the frontal lobes and in thinking, serotonin, which is involved not only in our mood and our behavior, but also in our movement and our strength, and norepinephrine, which eventually becomes dopamine and works both on motor recovery and cognitive and alertness recovery, are all heightened when we stimulate the brain with this electrical activity, which ultimately allows for more connections to exist or to develop in the brain, which then allows for that neuroplasticity to take over and for new synapses and new connections to be made, which improve your function. So, as mentioned before, this is a safe and well-tolerated treatment. It has been available as a procedure for many, many years, over 25 years, treating other diagnoses. And now it's available for people with chronic ischemic stroke. So the main things that you might need to know about if you were considering this is that many patients who have had these kind of strokes are on either antiplatelet medicines to prevent future stroke or anticoagulants like Coumadin, Eliquis, Xarelto, Pradaxa, especially if they have something called atrial fibrillation. And these are medicines that would need to be temporarily stopped to allow you to have the procedure done and then restart it again after. So you'd always want to talk with your surgeon and your primary doctor about how to safely bridge to having the surgery done and then having the medicines restarted. The good news is this is not a big surgery. And so for neurosurgeons, this is a pretty simple procedure. It's a same-day surgery. You go in, you have it done, you're in the recovery room for an hour or two, and then usually you're home the same day. So pretty easy procedure from that perspective. And then there's a period of healing before the device is eventually turned on and therapy is started. Most common side effects that you need to know about with this procedure is because the surgery is implanted under the skin and the device is stimulating the nerve in the neck, some people will get some vocal cord weakness for a short period of time. Certainly, anytime you open the skin, there's a risk of an infection. And so we want to prevent infection because if infection gets into the pocket area, then the device needs to be taken out. We don't want that to happen. Surgery can cause pain, but usually it's short-lived. And the most common thing we hear from people is they get a little hoarseness or change in their voice that occurs for a while, but that usually improves as well. So it's not a long-lasting complication. So how do we know this works? Well, studies have been done that have led to the FDA approval in this area. And so I can review with you what we know at this juncture. And additional studies are being done even now looking at other areas as well that we'll talk about. But when we compare vagal nerve stimulation to control, meaning that something was implanted but not turned on, and so that we can compare people side to side. They both have had a procedure done, but one's getting the stimulation and one's not. We see that those that received the vagal nerve stimulation had a significant improvement in what we call their Fugl-Meyer upper extremity score. So this is a measurement that typically occupational therapists will do, but any therapist can be trained to do it. We'll do one of those evaluations before your procedure to see where your baseline is, again, right before starting therapy, and then at the end of therapy and out further from the end of therapy to kind of see how your changes are going. And in this case, there was a significant change in the Fugl-Meyer functional score of the upper extremity in individuals who had the stimulator turned on, as you can see here. And that difference maintained 90 days after therapy. So therapy was finished. People continued to use it, some on their own, but there was even some improvement after the continuation of the aggressive therapy with people using it on their own. And that difference between the control group and the vagal nerve stimulation group remained statistically significant. Then after 90 days, the control group got their stimulator turned on, and guess what happened? they got the same kind of improvement as did the original group. And so they too met an improvement level similar to the vagal nerve stimulation group originally, and they too were able to maintain that 90 days out or beyond. So the good news here is this not only works during the time that you're getting the aggressive therapy, but it is maintained well beyond that. And it is something that you can continue to work on and use at home even after the therapy that was designed to be paired with the stimulator has ended. So that's exciting. And now what we see is that research is going on looking at walking ability, looking at talking ability. So we can't say right now that your walking is going to get better when you get vagal nerve stimulation. But it would make sense that if you work on walking, that your walking might improve just like your arm function might improve. Or that if you work on talking, your talking might improve just like walking and arm function might work. So we're excited about where this will go and what it might help patients with going forward. So in patients that are being looked at with for their upper extremity function, we are also measuring some of their walking ability and talking ability so that we can see, are there changes happening in those areas as well. And again, when they are being seen with the therapist, the big focus is on doing something functional. What is it that you want to do? I want to be able to open jars better. I want to be able to bring a cup to my mouth better. I want to be able to cut my food and feed myself. I want to be able to button my shirt. Whatever those tasks are that you're interested in, the therapist will work on those and focus on those 3 times a week for 6 weeks. And the goal is to accomplish repeating those tasks 300 to 500 times each session. I know that sounds like a lot, but repetition is the mother of learning and is a very important component of neuroplasticity. So that's a big piece of what has to happen in order to get this improvement that we're seeing. When a person is not in clinic, not with a therapist, they are then later able to use the magnet to turn the stimulator on while they're doing home exercises and then turn it off so that they can pair the vagal nerve stimulation with their own home-based exercises, which is also very helpful. And you can see some examples here of things that have happened. Here's an individual whose writing was very difficult, very hard to control. And then after some beginning of Vivistim, it improved. 5 weeks into Vivistim, it was much better. And then 8 weeks after Vivistim therapy, pretty legible and pretty well controlled, and maintained for several weeks even beyond that. So good improvements. Again, here's an individual who just wanted to be able to hold his grandchildren. And here's somebody who is very interested in their art and wanted to go back to drawing and painting. These are important things in our lives to give us quality of life and the function that we're looking for. And the hope is with increased upper extremity function after Vivistim, you can regain some of these things. Here's an example of a 51-year-old who had recurrent ischemic strokes and was really interested in doing some of the things at home. So you can see with the device, her right arm is the weak arm, but with increased activity and practice, she's now able to open a bottle, hold the bottle, squeeze it out, and use that right hand to help. Now, after the Vivistim, you can see that right hand is a lot faster, a lot more functional, and she's able to grab and use those things and use it as not just a helper hand, but a doer hand, which is, what is so important for so many of us is to have that hand actually do things on its own without just being an assistance to the other side. Another individual with left upper extremity weakness, you can see here before trying to reach and grab. He's got a little bit of shoulder, a little bit of elbow, and a little bit of hand movement, but not enough to be able to open the hand and grab the ball. And here you can see him afterward where he's grabbing the ball, letting the ball go, getting better shoulder movement, better elbow movement, and certainly better finger and hand movement than what he had before. His Fugl-Meyer score, as you can see here, improved from 33 out of 66 before Vivistim to 54 out of 66 after. He's now able to open pill bottles. He can dress more independently, and has been able to travel more independently because he can take care of himself. He can go to the bathroom at a gas station if he had to stop on a travel. He can help get himself dressed and so forth. So doing much more than what he was doing before the Vivastim treatment. So again, just to make sure that we're all on the same page, because this is exciting new treatment, but we obviously have to get it paid for and we have to get it into the hands of the right people. We're looking for adults over the age of 18, those who are willing to have a surgical intervention to treat their care, because some people don't want to have surgery or are afraid of surgery, and that's understandable. They have to have had an ischemic stroke, not a hemorrhagic stroke. They have to be past 6 months in time frame from their stroke and have chronic upper extremity weakness or deficits that are considered moderate to severe in nature, but yet the ability to move the shoulder, elbow, and hand a little bit, as at least relates to pinching or gripping and letting go. Doesn't have to be good function, but at least some movement there. And no history of bilateral or left vagal nerve surgery. They also have to be willing to undergo the therapy. So you have to know that you can get to 3 therapies a week for 6 weeks in a row, 18 sessions of therapy. That's asking a lot for transportation, for support, for the time to go to therapy. So you need to make sure that that's carved out and available in order to make this work. And then you have to be working with your physician to make sure that the tightness in your arm, we call spasticity, is under pretty good control during that period of time so that you've got the ability to work on strength. Strength is the enemy of spasticity. We take medicines to loosen our hands and our arms up, things like baclofen, tizanidine, dantrolene, or even injections like botulinum toxin, Botox, Xeomin, Dysport as examples. But the thing that really makes spasticity better is getting better strength. So this is an opportunity to see strength improve, and with that, hopefully spasticity gets better. We also like to see people that have, even if they have some sensory deficit, not such loss of sensation that they can't control their arm or their hand without looking at it. So that's an important assessment that we would do at the beginning to make sure that you have that. And again, we're talking about a little bit of shoulder movement. You can bring that arm out a little bit from your body, from your chest, a little bit of elbow movement, either in flexion or extension, and then a little bit of hand movement, either in gripping or releasing something in order to really be an ideal candidate for this treatment. So the American Heart and the American Stroke Associations have policies regarding what they recommend for people as part of their recovery after a stroke. And rehabilitation is obviously still recommended even beyond the early stages, because they know that when you really focus on functional gains and functional tasks, as we've talked about, that people can show improvements that go well beyond the first 6 months or year after a stroke. It used to be that we would tell people that a year and a half out, what you've got is about what you're going to have. But we really don't believe that anymore. And we know that if we use some of the new technologies like Vivastim, aggressive therapies, new robotic devices, and things of that nature, we see people making improvements that go out sometimes many years beyond the time of their initial stroke. And so I think it's important to make sure that we give these resources to people, that people know what's available to them. So large academic centers like the University of Louisville, where I'm at, other big academic centers that may be in the communities that you live in, they're pretty familiar with these techniques and these kinds of treatments. So those are the individuals that you probably want to seek out to really find what's new and on cutting edge in your local community. Always look for therapies that are goal specific and task specific. What are your goals? Not what are the therapist's goals? What are you wanting to accomplish that would make your life more functional and better? And that's the kind of things that then therapists can work on with you using repetitive activity technologies and things that help neuroplasticity like Vivastim to improve your function and quality of life. And so, we've talked about how so many stroke survivors are looking for additional improvement and additional treatment well beyond the early stages. You come into the hospital with a stroke, you receive your acute care, you transition into either inpatient rehab or home with outpatient rehab. Those first 6 months or so are pretty well scripted in American healthcare for most people. But it's beyond that stage where we start to get a little fuzzy. And so, these kinds of treatments are now available to help people continue their improvements well beyond the first 6 to 12 months after stroke. And as you might already know, it takes a lot of people with a lot of know-how to make some of these things work. And so you might say, well, I'm interested in Vivastim, but where do I go and how do I know who to talk to? Typically, your neurologist or your rehabilitation physician, if you have one, known as a physiatrist or physiatrist, will have some knowledge about this new technology. If not, they would know who to refer you to for that knowledge. And typically, the physician would determine if you look like you're a candidate based on some of the determining factors we talked about. And ideally, they would refer you to a Vivastim program, a place where they're doing Vivastim, which would then allow you to be evaluated with a Fugl-Meyer score by a therapist. And if deemed appropriate, would then be referred to a surgeon to talk about what surgery looks like and what the typical plan would be, with a goal of once it's implanted, it has to go through insurance approval. And then once it's implanted, you've got a set place and a set time to begin outpatient therapy. And you've got yourself set aside the ability to get there over that 6-week period. And so that's the typical kind of process. What we're seeing at the University of Louisville, where we've done a handful of these treatments, where the second place in Kentucky, the first one in the Louisville area and its surrounding areas, is that it takes about 2 months from the initial evaluation to get insurance approval and therapy scheduled, or surgery scheduled. And then once the surgery is scheduled, about 2 weeks to let things heal and recover, and then therapy begins. And so you're thinking about a 4 to 5 month period from start to finish to give you an idea of the time frame that all of this takes once you're seen by somebody for consideration of Vivastim. And as you can see, there's a lot of people involved. It's you, it's your family, your support system. It can be therapists, physicians, all kinds of people who you might interact with that go into making this a successful activity. And so certainly, depending on where you live, there's somebody within a short drive or a short distance of you that probably is either aware of this system or is starting to implant this system for the right candidates. So I encourage you, if you're interested, to seek more information and to reach out to your local providers. And as mentioned, there's a lot of people involved. We had to go through months of getting insurance approval for our system to even do it and to make sure that we were going to get paid appropriately for the surgery. Then we had to put a team of therapists together to get used to how to evaluate patients and implement the treatment plan. Now we're doing an evaluation clinic where we're seeing people, determining as physicians if we think they're candidates, sending them for the therapy evaluation, and then if they're appropriate at that point, sending them to the surgeon to discuss the intervention, all before we even send it off to insurance to get approval for treatment. But the good news is, the studies are very, very encouraging. What we've seen in the patients that we've had go through it and complete it so far is they're very happy with the changes that they've made. Are they back to normal? No, but have they got significantly improved hand function? Yes. And I think that's really what people are hoping for, is just to be able to do things like hold a tool, maybe go back to playing an instrument, painting, whatever it might be that gives them the quality of life and the functionality that they're looking for. The hope is Vivastim can help in that regard. And you can certainly talk with your physicians and your therapist about realistic goals. But I would say most people who go through this are generally very happy that they've put the time and the effort into it to not only investigate it, but to have it implanted and go through the therapy, because they end up with a better function and a better quality of life. So these are just some references. Certainly, I'd be happy to forward those to anybody who's interested in that. But you can go on to the ViviStim, VIVISTIM site, and a lot of these resources are available for you there if you want to read any of the articles. This was the topic of discussion at our most recent national meeting that we held last month in February. Listening to other experts around the country like myself who've been implanting this and what their experience is, generally it's very favorable, and we're all very excited about new indications coming down the pike, not just upper extremity use, but better walking and better talking eventually as well. So we're hopeful that patients with different stroke symptoms and individuals who had different kinds of strokes may be included in eventually down the road as well. So with that, I will turn things back over to Sherry to help guide us through a little bit of a question and answer period. Sherry?
Great. Thank you, Dr. Kaelin. And that was an extremely thorough presentation. So thank you so much for doing all the legwork up front to anticipate what everybody's questions might be, and also weaving the conversation of neuroplasticity into that. So it's very much appreciated. Thank you.
Absolutely. My pleasure.
I do have some questions, and I want to make sure everybody knows to put their questions into the Q&A box, not into the chat, please, because the Q&A questions come straight to me and Dr. Kaelin, so we can see those. So please do drop those in there. Dr. Kaelin, I'm going to move directly to some of those questions. I have some questions of my own, but a couple that have come through so far is there a minimum score on the Fugger-Meyer scale that would
Yeah,
be
I don't know that there's a minimum score. I think I did see that there was, they kind of assess, I want to say a 24 maybe is kind of an average low score. But I think more importantly, we're just simply looking for some activation of the muscles of the shoulder, elbow, and hand. You know, many people who come to us who are just so weak that they can't move it at all, or who are so tight that they can't move it at all, then what we often do in those cases is we say, let's work on managing the spasticity so that the muscles are less tight, and then let's work aggressively on trying to get some movement or activation in the hand, elbow, or shoulder. And if those kick in, then you become a candidate for ViviStim.
Okay, got it. I wonder if you would please take just a few minutes and explain what the vagus nerve is in just a little bit of detail and why that's so important, right? Because it is
Yes.
a unique system itself, and our feedback loop maybe is a better way to describe
Yes.
that. And so we've got some questions around that. Why the vagus
Sure.
nerve?
Yes, that's a great question. So the vagus nerve is the 10th cranial nerve. So cranial nerves are nerves that don't come out of the brain, but come out of the brain stem, which we think of as being just below the brain, kind of in the upper part of the neck, and that lead into the spinal cord. In my mind, I would tell you that I think of the brain stem as actually the spinal cord that sends messages out to the head and neck, as opposed to the spinal cord that sends messages out to the arms and then eventually the legs. There's not a lot of thinking, or really no thinking, in the brain stem, but these nerves that come out have very important functions for eye movement, mouth movement, taste, smell, hearing, balance. The vagus nerve, its job is kind of interesting in that it does control some of the muscles of swallowing, but it also goes down to the heart and to the stomach. And so there are some regulation of those functions with regard to heart rate and stomach acid and things of that nature. Those are heavily involved on the right side more than the left. So that's one of the reasons we choose the left vagus nerve, because when you stimulate a nerve, it both stimulates the messages up to the brain as well as down to the organ that it goes to. By stimulating the left side, we have less side effects than if we stimulate the right side. And
Okay.
so that's the main thing, the main function of the vagus nerve. But you could potentially, and we know in other cases, we can stimulate other nerves of the body, the median nerve in our hand as an example, and still get activation in the brain. We just haven't done it in a way that we can prove that it's as effective. So by stimulating the vagus nerve, we know there's an effective activation of the brain that allows neuroplasticity to take place.
Okay, awesome. That was very thorough. A question, quite a few questions about the vagus nerve stimulators that you can buy on the open market over the uh, um, Amazon
Yeah.
versus what Vivastim does. Can you speak to that?
Yeah, it's a great question. The answer is we don't know because um, it's like anything that a doctor prescribes you. If I prescribe you a pill, am I prescribing you 5 milligrams or 10 milligrams? Am I giving it to you once a day or twice a day? So we're looking at dose and frequency and effectiveness. And what we don't know with the external stimulators yet, because they are being looked at, is which ones are effective, how often do you have to use them, and at what intensity and during what period of time. So until we know that, we can't tell anybody use this device or that device because we just don't have the answer. Many of them are showing no harm, but we don't know yet whether any of them are really helpful or not. So will it hurt you? Probably not. Will it help you? We don't know.
Okay, and how long do you think somebody should give that a try before they say, I don't think this is effective for me, if it's
Yeah,
external?
I would say my opinion would be if you do it on a daily basis with with therapy going on right after the stimulation is done, or with activity, stimulating with activity, then I would say you probably want to do at least 20 sessions out of a month for 2 months before you know it's going to help or not. So a 6 to 8 weeks of home-based therapy with a external vagal nerve stimulator to see if you've made improvements or not before you give up on it.
Okay, good, good. I had a question for you on sort of the you brought up in your conversation in American with rehabilitation, right? Are you using Vivastim, or is Vivastim being used differently outside of the United States to treat a wider capacity of challenges?
Well, that's a great question. I don't know the entire answer to that, except for to say, in my experience in working with individuals in other countries, is certainly if you're in the European Union, they have similar restrictions to what we have in the United States as far as what's allowed and what's not allowed. But when you start getting outside of those first world countries into Eastern European countries, African countries, Asian countries, there's a lot more looseness and restrictions. And it used to be that America was teaching the world how to do things. We're now seeing the world starting to teach America because these technologies are now available in places like Africa and Asia where they weren't before, and they're being tried in different ways. And so, yes, I think there are probably techniques and technologies that are not currently proven in America that are being used in other countries. So is Vivastim or something like vagal nerve stimulation used in other ways in let's say China or in Indonesia or in South Africa? Very possibly. But I haven't really seen the research on any of those yet. And so even if they are working in those areas, I don't know that they've been published heavily enough to say, go travel to South Africa and get this done. I'd be very careful about things you find on the internet because many of those things are driven by money and not by outcomes. And so don't let yourself be fooled for 5, 10, 15, $20,000 to get something done until you see good, clear research that it's effective.
Yeah, I think that's solid advice right there because I get questions on a regular basis about stem cell therapy, this, that, and the other. And it
Right.
is just so reflective on who, where, when, and what. And you've got to know all that information and do the research. So I'm glad
That's
you
exactly
threw
right.
that caution flag up there.
Right.
Um, so, Dr. Kaelin, just kind of stepping back outside of Vivastim for just a second. Well, actually, no, I'm going to pivot there. I've got one more question on that before I go into some other questions. So it seems to me that Vivastim is really creating a window of neuroplasticity, accelerating that neuroplasticity in the brain. And then you combine that with a more traditional type of rehabilitation to accelerate the effectiveness of that traditional rehabilitation. And if that is accurate, what else could individuals do who are using Vivistem or who are using some other, maybe even the external Vivistem, to help expand and enhance that window of neuroplasticity in the brain? Are there medications that you pair it with? Is exercise something else that you would recommend? Any other type of supplements that you encourage to enhance even the use of Vivistem, internal or external?
Yeah, great question. Hard to answer with any definitive response, but I will give you my opinion. And again, just take it as that, not based on any evidence. A healthier lifestyle with good nutrition, less processed foods is helpful. I'm a red meat eater. I know I'm not supposed to do it. I tell you that most people will tell you a Mediterranean diet is the better way to go. So I'm not going to argue with that because I think it's true. Limiting, but not exclusively getting rid of alcohol. I think, having some is okay. Having a lot is not. Obviously, smoking and vaping and marijuana, although marijuana might be effective for reducing pain, anxiety, seizures, and even spasticity, probably not good for our nervous system as a whole. But exercise is medicine. And so I tell people anything you do is better than nothing you do. And pairing it with things that excite the nervous system is important. I may not have done a great job of explaining this at the very beginning, but I'd like to give you a different analogy. What we're learning here at the University of Louisville and the Fraser Rehab Institute through our research on spinal cord injury as well as on brain is that the nervous system works a little like a dimmer switch. If you've ever had one of those in your house, it's not just an on or off switch, but is it the light turned all the way up or is the light turned down middle way or all the way down? When you have an injury to your nervous system, then the dimmer switch is turned down, and it's turned down sometimes to the point where you can hardly tell it's working at all. And what happens with electrical stimulation, whether it's stimulation through the vagal nerve, epidural stimulation to the spinal cord, is that it turns the dimmer switch up and makes the nervous system more receptive to external stimulus, to activity and things that you're doing. So when you're building strength, it's not just what happens with the messages going out, but it's also what happens with the messages coming back from the body to the brain. So the brain knows there's an arm and a hand out there to use. There's a foot that needs to take better steps. And so the electrical stimulation seems to be making the nervous system more receptive to messages, which then makes it more plastic and makes it reach out and make better connections. And so that's kind of how I think of it working. So having a healthy body and a healthy nervous system through nutrition, exercise, medications, blood pressure control, cholesterol control, very effective. But exercising and using some of these new technologies, lots of repetition is what's going to make you better over time.
Yeah, thank you for reinforcing that. The speaker right before you was Michael Lover with Bionics, which are those
Yes,
exoskeletons. And I don't know if you heard
right.
any of that, but he was talking about really it's maybe the step before you get to the use of Vivistim, which is using those exoskeletons to create movement where there is no movement. I don't know. I mentioned that to you because that would certainly be an interesting partnership to really put those
Yes.
two together.
Well, we have the exoskeleton here at Fraser Rehab Institute. We definitely use it both as a therapeutic device to help build recovery, as well as a external prosthetic device to help with function, right? So you have to think about new technologies in both of these ways. Can it be used to help the nervous system recover? And can it be used in place of the nervous system when it isn't working to do something you want to do, in this case, exoskeleton for walking? So it could certainly be used at the early stages of recovery to help you develop a movement pattern and to start moving when it doesn't exist there before, and possibly even be paired with things like electrical stimulation. In the case of a spinal cord injury, epidural stimulation to the spinal cord. In the case of a brain injury, a stroke or something, maybe vagal nerve stimulation, external vagal nerve stimulation, even deep brain stimulation has the possibility. But right now, what's FDA approved in this area is the Vivastim for chronic ischemic stroke.
Yeah. Well, and that was kind of my question around outside of the United States. Can you get it for use with some of the other things? But you covered that. I want to ask our audience now. You've got a poll coming your way, please, to help rate this session and let us know what worked well and where you'd like to see some improvement and what sort of if this is the right level of information for your use. Please let us know. We do take that to heart. So as you're doing that, I've got one or two quick questions here remaining for Dr. Kaelin. If you do have any other questions, throw them in the Q&A. We've got time for, I think, two more questions. One of those, which I'm going to ask right now, which is, Dr. Kaelin, in the introduction, I talked about how you're sort of relentless about learning for new other technologies that are out there and applying them. So I'd love for you to share anything that's exciting that you've learned about coming down the pike that is you could use with Vivastim, without Vivastim. It doesn't have to be related to stroke. It can be in some of the other neurological challenges you treat as well. So what's
Absolutely.
exciting?
Well, I'll give you two things. Number one, the first thing I will say is that nothing by itself is going to fix everything, right? There's no magic cure or no magic pill to neurologic disease and loss of function. So your point earlier, which is pairing things together, is where I see the future. Well, so it's going to be using a certain medication that might increase dopamine, serotonin, or acetylcholine, along with Vivastim, along with therapy, et cetera. Those things are probably where we're going to go. Things like virtual reality. We know using the brain stimulates the parts of the brain that actually physically move, even if we're not physically moving. Just thinking about moving stimulates those parts of the brain. But the new technology that is coming down the pike that I think is going to be very interesting with people with chronic debilitating neurologic disease is going to be what we call brain-computer interface, right? The ability to either have a chip or some kind of device either on the external part or implanted in and around the nervous system where you can think to do something and then the computer does it. You can think to talk when you can't talk and it talks for you. Or you can think to move your hand and a device, external robotic device moves your hand for you. I think that is what we're going to see happening over the next 5 or 10 years. Of course, that stuff starts off very expensive and then over time gets easier and less expensive. But I do think there will be a time over the next decade where we'll see these devices being used more commonly among the population who has very limiting neurologic disorders. So there's a website you can go to called Neuralink that is very focused on this area. And I would encourage you, if you have interest in this, to look that website up.
Yeah, thank you, Dr. Kaelin. And just one quick question. I know that people are asking, where do I get Vivastim? And you mentioned that. I do know that you can go to the Vivastim website and you
Correct.
can put in your zip code. I'm not sure if you have to put in your zip code or your city. Anyway, they have a locator and you
Yes.
can find one closest to you. So I know that that's there. We've got one last question, and I like this question a lot, actually. It's, can Vivastim enable an indirect improvement in walking or some other type of function by being able to swing your arm or gaining that upward mobility? So what are the indirect impacts?
Yes. So my unproven answer is yes. I think it will improve gait and or speech if you work on those things during the stimulation process. That is being studied, but it has yet to be proven yet. So I'm very excited about the results that are coming. So I do think there's potential for that. So if you have arm weakness and you're a candidate for Vivastim and they're working on your arm in therapy, it doesn't mean that you can't also walk or talk or use, if you have aphasia or language issues, to see improvement in those areas as well. We just don't have the evidence yet that it's proven for those areas. But I'm very encouraged by what I see so far. And so I think for those individuals who are thinking about having it implanted for the arm, but also have leg weakness or speech problems, you should definitely work on those areas as well.
Okay, very good. I think that's the perfect note to end on. Thank you so much, Dr. Kaelin.
Absolutely. Well, I will just say this. We started off the gates slow, as we say in Kentucky, but we finished the race strong, and I appreciate everybody hanging in there with me, and it's been great being part of this Rewiring Hope Summit.
Thank you, Dr. Kaelin. See you in Kentucky.
Bye now.
Bye-bye.